be honest, that wasn't the worst complication I think we're going to see today. And up next is pleasure to introduce Dave Pauly, and he's got a good one, I think.
So I don't know whether it's good or bad to be invited to speak at the NASCAR session, right? Because you go to NASCAR not to see the race, you go to see the crashes. And so that's sort of the approach. And I guess I first got invited to talk like something like this. The neurosurgery group had a complications meeting that was a QI process, and you signed a non-disclosure agreement, and that there were significant discussions. And the discussions were informative and useful. How many people in the room have had a major vascular event during your surgeries? Is that one of the, I think, and when at these complications conference, I think the vascular events were the things that most got our attention. And that anybody here ever had a partner or have someone get a major vessel from behind? Yeah. And I can't think of anything that scares me more than having something like that happen in a outpatient ambulatory surgery center. I mean, it's scary enough if you're in a major medical center. So let me share my stroll down memory lane, and it's sort of like, oh yeah, I need my disclosure. So Jim, this is for you. I did make $53 last year from a textbook. All right, so 63-year-old female that I had seen for 3.5 years of non-operative treatment. She started out, I think she was at about 300 morphine milligram equivalents of narcotics per day when I first saw her. And I said, you know, you got to get down. And at that time, our thinking was you had to get below 120 a day to avoid the post-op hyperalgesia kind of pain. And so we worked and worked and worked at that. Reasonable human being. She had been cleared by everybody. We had maxed non-operative treatment, BMI 38, so cachectic by Jim Harrop's standards. But you know, she wasn't going to lose the weight. It just wasn't happening. But she did quit smoking. So she quit smoking. She brought down her narcotics. We went at this for 3.5 years. Here are her x-rays. So somebody else had done a big wide laminectomy on her, and you can see that lateral listhesis, and I think the abdominal surgery, I can't remember if it was a gastric bypass or not, but previous abdominal surgery. And
given those x-rays, was there any utility to getting the discography, or did you order those?
I can't remember if I ordered it or someone else did. I think she probably came in to me with it. For me, it's like, all right, this is a deformity problem. I like Reg Hade's line that we're all deformity surgeons. We either create it or we fix it, and sometimes we do both at the same time. And that, to me, this is a lateral listhesis and an instability and not a horrible alignment problem, but more of an instability and translation problem. That lateral listhesis is a bad sign when that occurs. So her MR imaging, so when she lays supine, she reduces a little bit and it doesn't look as bad, but 2 levels clearly look bad, and then we're back to that question about if you're fusing a couple of levels like that, do you do it a floater or do you leave 5-1 unfused or not? And so we had multiple discussions multiple times, and so our plan was a front-back. With the dense adherent scar from the wide laminectomy, I very much like doing T-lifts, but I thought that this would be a better, faster way for her. My access surgeon had done more than 5,000 anterior approaches. He was a cardiovascular guy, and half of his practice was spine exposures in the Twin Cities, and he was extraordinary. And so that affected. I could do it faster with him than I could doing it as a posterior-only procedure. And so that was the plan going in. And we did the anterior approach, and so here's the fluoro spot. You can see this is now a decade ago, but we got good disc height restoration. And then the posterior, as we're checking things, okay, things look...
Was this open or percutaneous? Or?
No, this was open, a revision, open anterior posterior, and she needed, in my opinion, some direct foraminal decompression because of the bony stenosis. And so here's her lateral x-ray, and so I'm pretty happy with how that looks. And the front part, well, and here's the imaging as we're leaving the OR. And so the anterior approach took a little bit longer than usual. He mobilized things very well and got the great vessels across so I could really take that lateral listhesis segment and get it cleaned out and replaced. 4 hours, maybe a couple hundred cc blood loss, nothing impressive. And one of the things I didn't realize he did that he told me about that he does on all the patients is after I put the spine stuff in and I say, okay, and he would then close it up, he would check the pulses in both iliacs prior to closing, and he did that and it went fine. And then we did the posterior part, and that went relatively straightforward. We knew she was going to be a pain problem, and so we had put in an epidural catheter to help deal with the pain post-op, and she had substantial pain in the recovery room. Okay, not too surprising given the magnitude of surgery and her preoperative narcotic use, but it was actually the intern who checked on her and said, I'm not feeling any pulses in her feet. And that it wasn't the nursing staff, it was the intern on the service. And that intern definitely got kudos, and it's like, okay, why is she pulseless in her feet? And my thoughts were, did a graft kick out? Did we have something occluding the great vessels? What's going on? So we went immediately to CT scan. Everything was where we put it. Okay, that looked appropriate. And I called my vascular guy back and said, hey, we got a problem. And he said, well, let's bring her back and open her up. And we did. And she was pulseless in both iliac arteries. I was like, okay. So he attempted thrombectomy and couldn't reestablish flow. So the place that we operate and do our spines at doesn't routinely, it's not the site where our vascular surgeons do their reconstructive work. And so he was, at this point, he was quite concerned and worried, and we had a discussion about what do we do now? Do we try to do a vascular reconstruction in a facility that's not routine at doing this? And his facility where he did all this stuff was about 10 minutes away, and he said, I would rather take this person to the place where I do this all the time. And I said, okay. We made preparations. He called the OR there. They rolled from our OR to his OR at that place, and so the time between ORs was about 35 minutes. And he did an aorto bifem bypass graft, never really got great flow. She developed bilateral compartment syndromes, went into renal failure, and was on pressors. And then we got to have a wonderful conversation with the family and say, what is it that you want to do? We can save her life potentially by doing bilateral lower extremity amputations, but that's what it will take, and she's still got the renal dialysis problem and everything else. And that the 3.5 years of knowing them beforehand was probably the best part of being prepared for this. And what her husband said that I will never forget till the day I die is that he said, she lives to walk her dog. If she can't walk her dog, she doesn't want to live. And that actually made the decision about as easy as it could be, and they chose to go comfort care at that point. And so every patient that I talk to, and it's sort of a rote phrase, but I say to every patient that I'm taking to surgery, the risks of surgery include the risks of general anesthesia, including death. And then I go through heart attack, stroke, blood clot, pneumonia, and then the surgery-specific risks. And I've never been sorry I've said that. But what we thought in retrospect is that she probably had a soft plaque in her aorta, and that with the mobilization, we probably dislodged that soft plaque, and that resulted in the distal embolization.
So Dave, thanks for sharing that. That is indeed a very bad complication. Do you think there could have been anything done preoperatively to identify these patients who are at risk for getting these types of complications? Is there any optimization that could be done on these patients?
Right, so you have sick people, so she'd been a smoker, she was a diabetic, and she was obese, okay. We did 3.5 years of non-operative management, and we were aggressive about that, so I don't think we could have done any more there. And on this one, I deferred to my vascular surgeon and asked him, what is it, could we have picked this up? And he said, I don't think anything would have really shown us this. And you go back and you look at the CT scan and you see aortic calcification. Okay, well that's fairly common. And she didn't have evident distal vascular disease at the start. So I don't know that today I would have done anything different, but I just want to share that concept of the patient with expected severe pain post-op and then paying attention to the vascular status, and that it was the intern in the recovery room who picked it up, and that was absolutely the right call.
We'll go to questions.
Yeah, a comment. I've had two similar cases, except not as severe. If you have a patient that has vascular disease and you can see a bone density in the aorta that exceeds that of her spine, then you've got a little bit of a problem potentially. But one thing I've done fairly routinely is put a pulse ox, particularly on the left foot.
Yeah.
And early on, before I took it off, I do the posterior procedure, and I had a similar case. A guy woke up with basically a dead leg, and they were able to save it, but he still has chronic pain for that. He has no back pain from his spondy. So what I do now, in fact, this was the advice of Sal Brow, who did approaches in the LA area for decades, that you leave the pulse ox on the left foot especially for 24 hours after the anterior approach is done. And if you do that, you're at least going to diagnose it a lot quicker by knowing what the oxygenation is in the foot. And you expect it to go, in fact, when you do this intraoperatively, and you're particularly at 4-5, you're going to have a drop in oxygenation in the foot for the duration that you have the retractors in for that level, and maybe at 3-4, generally not for 5-1. But this is, if you do that, that will at least allow you to have the early diagnosis of this, and whether or not you could have saved a patient in this situation, you may not, I don't know, but at least gives you a little bit more time, less ischemia time.
So I've used that actually in lumbosacral agenesis patients and creating a spine for them, and the question is how much distraction could we apply, and the thought was until the pulse ox started dampening, and then we had maximum vessel stretch. But that concept of a pulse ox on the toe is a great comment.
Go ahead.
Yeah, hi, Dave. Quick question. The age of this lady was?
60s.
Yeah, I mean, I think that in some situations you have a medically infirm patient who has pain and bad films and complains of pain, and your choices are no surgery, small surgery, or big surgery, and I think sometimes big surgery is too much for certain people, and it just can't. Sometimes you have to be willing to say, we're not going to do big surgery, it's too much for you. What I have a question of on this is, I find it really, really hard to envision the scenario that he, at the end of the front part of the case, felt good pulses, and then at some point later those were lost. That's very difficult to put that together.
Yeah, I can only tell you, and again, that I've gone through a series of vascular surgeons, some of whom I would tell you, it changed my practice and I went posterior instead of going anterior. This guy I would go into battle with any day on any problem, and it's sort of like, how much do you trust him? And this guy, he would, he was my guy and was the best we had, and I didn't even realize that he routinely did it, but he told me that, and then I went back and looked at some of his op reports, and he routinely dictates that he does that. So
I don't doubt he dictated he did it.
No,
I have a couple questions. So was there any evidence that this patient had coagulopathy?
No.
She threw a huge clot bilaterally, I'm assuming? No evidence.
No evidence of that. Yeah, and the family declined a post-mortem. We actually asked, and at that point, I'm not sure I was ready to push them for anything. So.
And my second question was, when you look at this X-ray compared to your post-op X-ray, clearly you did a lot of lengthening anteriorly. Was there any tension or anything that you could perceive at the time of surgery about that?
So again, I was sort of like, at the end of the anterior, like, okay, that went reasonably well, okay, and we had built it back, we built it up from the bottom up, and everything. I thought things had really gone about as well as they could, and I was feeling pretty good about the case. And then that recovery room call came, and then things sort of went south fast.
Okay, 2 quick questions. The back microphone first.
Ahmed.
Dr. Nasser.
Oh, thank you. One of my partners, Paul, taught me to put a pulse ox on the toe. I'm not sure, do you guys routinely do that? And I've been finding that after a certain amount of retraction, sometimes the pulse ox will go down. And interestingly, sometimes it doesn't come back up immediately after you've released the retractor. So I'm just wondering, are there other phenomena at play here, like vasospasm or other things that we probably don't understand as well? But sometimes those vessels can look pretty beat up if it was a long retraction time. So just curious about your thoughts on the utility of that. And
Yeah, so we didn't do a fixed retractor. We did handheld retractors, and we did it level by level. And so that's as good as I know how to do it. It was that lateral listhesis one where we were really bringing the vessels over to the right pretty far in order to get that cleaned out, because I didn't think I was going to get a good realignment unless I got that annulus released on both sides. And so I worked a little more at that one. It usually takes me about 20 minutes a level, and so we worked a little harder at it, but it didn't seem excessive. And so again, I was flat out surprised by this.
Can I just ask from the audience, does anybody else use a pulse ox on the toe to kind of throughout? And do you guys notice that even with handhelds that sometimes it'll go down?
Yeah.
I've noticed it as well. So
Yeah.
Okay,
Real
Mike.
quick, Dave, in the recovery room, was she neurologic? Was she moving motor-wise?
She was in so much pain that she was writhing around.
Okay.
And,
I just wondered, if she stroked her core, was it a higher vascular?
her upper extremities seemed to be fine, and she was moving the lower extremities, but it was sort of a flail kind of movement.
But I think the bigger thing here for me, if you look at the mortality and morbidity data for people in the Medicare population for anteriors, it's like night and day. You have higher mortality, morbidity, length of stay, all the 30-day readmissions, everything. And I think I used to do this more, but when I see a Medicare someone who's 65, 70, I don't even consider going anterior at all anymore. I'll do it. If you look at this now, you could probably get enough by just going posterior. Would you do the same thing? Would you do an anterior posterior now? Same thing on?
Well, that's a great question, and I certainly have done cases like this all posterior with T-lifts, and I'm very good at that. At the time, I had one vascular surgeon for a while who it took him 7 minutes to get the exposure for me. Literally 7 minutes, skin to spine. And I can't do that many T-lifts as fast as that could get me there. And so that was my thinking at the time. After you have something like this happen, or after you've had significant major vessel injury,